Welcome, everybody, to the annual Advantage Health Plans Trust user group meeting. We appreciate everybody's investment of time and effort to come down here. We always appreciate seeing our customers close, customer / owners, as seeing you all up close and personal. We're very happy that you all come down once a year and do this. My cohort here, some of y'all may not know Melissa Nance. Melissa's been with us for several years, but as recently we've promoted her to Chief Brand Officer, so she's going to be kind of riding shotgun with me during this presentation. She's really in charge of all of the keeping you all happy. So anything having to do with new business or keeping old business or legacy business, that's on Melissa's plate now. We also would like to join or say hello to all of the bankers that are joining us remotely. We are live streaming this over the internet, so if you weren't able to make it, this is also valuable for folks that are not able to make it to the Skirvin today. So. With that, Melissa, you see any reason why we shouldn't take off?
I think let's start.
Okay, well, let's go. Some of the topics that we're going to discuss here this morning are plan performance, and reporting. I know probably 9 out of 10 of y'all are here because of the 2020 renewal information. You can get it a little bit earlier than what we sent out via snail mail, and we'll talk about that for sure. Melissa's going to talk about some new plan changes where we're doing some plan enhancements in a few areas, and then also some new plan options that she'll go through those. We also have kind of a new topic section here, things to know. They're really just kind of topical areas that we feel that are important in your bank, things that we actually hear from our bankers. As far as questions and things of that nature, we're going to certainly go through those. And then also, we're going to have Troy Stillwagon, which is the Kempton Group's Chief Information Officer. He is here today also, and he's going to talk a little bit about some enhanced technology projects that are going to be rolling out to the bankers of Advantage Health Plans here in this open enrollment season. With all of that being said, you may notice that Maria is not sitting next to me, and I don't know if anybody saw the email announcement, but it was not very long after this meeting last year that Maria Robles Myers passed away, and we would like to just at least recognize and say a couple words about Maria. I knew Maria back when I was a kid. She had worked at Crow and Dunlevy for several years, and she was assigned to this banker-owned health plan way back then, along with another attorney named Gene McDonald. And they worked very closely together with Advantage. And as things changed, Maria went out on her own, and she retained one of the clients, and that client was Advantage Health Plans. And I think she's helped. She's certainly helped us and the Kempton team in the administration of this plan, compliance, everything else. But I think she's also been a good friend and a very reliable source of information to many of you all. I know there's a lot of relationships that were formed there, and Maria will most certainly be missed and certainly not be able to be replaced. From a business perspective, as you all know, Maria was the trust counsel, and really any of Maria's time, if you were a member of Advantage Health Plans Trust, you had essentially full access to Maria for things pertaining to this health plan. We've kind of shored her, missing her into a couple of different categories. We are partnered with a law firm out of actually Boston, Massachusetts, known as the FIA Group, and they also provide us the member banks here, unlimited access for any compliance questions that have to do with AHP or your health plan. That is also available at no cost. It's being picked up it's a trust expense on the banker's behalf. That's still there. And we also have kind of an interim trust counsel for the things that are a little bit more detailed in nature, with another ERISA, very reputable ERISA attorney. She's actually out of Billings, Montana, but either the FIA group or Mrs. Cook, her name is Corey Cook. She's out of Billings, Montana. Any of those questions that you all might have, those are things that those are expenses that are borne by the trust, and you can always access that just by calling the Advanced Health Plans offices. So, any questions on that? Moving on to performance and reporting. Some of the things that we actually had a Community Bankers Association of Oklahoma board meeting in this room actually yesterday at 3 o'clock, and we continue obviously to see consolidations in the community bank space, not just in Oklahoma but all over everywhere. One of the nice things, Community Bankers Association of Oklahoma, one of the things that they discussed at their board meeting, even though the number of banks is decreasing, the membership in the Community Bankers Association is increasing. So they were very, very proud of that. I can report the same thing on Advanced Health Plans. Even though the number of charters are going down, our penetration into the community bank space is increasing. Do have right around 130 member banks. We're operating in Oklahoma, Texas, and now New Mexico. I think last year we had discussed the endorsement by the Independent Community Bankers Association of New Mexico last year. Melissa and her team have written a couple of banks over there, and I think nobody was interested in being first, but they seem to be lining up to be second or third. So that's good. Number of employees in the trust, 30 as of last month's billing, 3,164 employees. It's right under 6,000 members, belly buttons, that are in the plan. So we're very happy with those numbers. Talking about medical claims and prescription claims by year, I think it's important when we look at, from 2015 to 2019, obviously we've seen an increase in medical claims and prescription claims. It's also, though, important to keep those in the context with enrollment. As we add more and more bankers to the program, more bankers are going to have more claims, they're going to spend more dollars. And so it's superimposed the enrollment, employee enrollment of the trust in each one of those years. So in 2015, we're about 2,570. We're at 3,164 this year. I don't think medical inflation being a positive number is going to surprise anybody out there. It is. I think some of the numbers that we've been seeing this year are indicating an overall national medical trend inflation rate, essentially for healthcare, is running a little over 4% nationally. On the medical side, prescription inflation is down a little bit. It's not negative. I don't think it's ever been negative, but it's about 2%. So we've certainly have seen that. But we have seen an uptick in claims and prescription claims here in 2019. As you all know, when we're up here reporting on the plan, again, we are privileged to be able to report these plan performance numbers, to a group of owners. This is your plan. It's not our plan. This is as close to a captive insurance company. Of course, the Oklahoma Insurance Department wouldn't want me to call it an insurance company because it's not. It's partially self-insured, but it is essentially as if every member bank is a partial ownership in a little captive insurance company. And so making sure that our self-funded benefit plan, your self-funded benefit plan, is strong physically is a top priority of your trustees. Again, you all have 7 elected trustees that represent your interest. I think we have maybe a couple. I see Priscilla in the back. Are there any other trustees present today? I don't think so, but so Priscilla, any questions, positive or negative, you're it, so just teasing. The board, it is amazing the level of understanding and involvement and dedication that the board has to being good stewards of this plan on behalf of you, the membership. So anyway, looking at total net assets available for benefits, we have had a very, very good run from really 2015 to 2018 where total trust assets, even though the rate adjustments were very, very low, very, very moderate, the trust was still gaining surplus every year there. We have seen a slight dip. We've seen on the previous slide, we saw claims that are going up. We have seen a slight dip in total trust assets. I think it's important, though, to know, well, is that a lot of surplus, a little bit of surplus? How robust are these numbers? And so we have superimposed that red line. You've heard us talk before that Advantage Health Plans, in the eyes of the different state insurance departments and also in the eyes of the Department of Labor, Advantage Health Plans is a MIWA, a multiple employer welfare arrangement, and because of that, we are required to maintain a license in the states in which we operate. Oklahoma, Texas, and New Mexico all kind of follow the same logic, I guess. It's actually kind of a suggestion, a best practices, if you will, that was established by the National National Insurance Commissioners Committee, whatever, I can't remember the exact acronym there, but and what they require is for a licensed MIWA, they need to keep 20% of the annualized contributions into the trust. You must keep 20% of whatever that number is as a reserve number. And so that is that red line that's there. So as you can see, the trust is way in excess, almost double of what is required by law to keep in place. So the trust is still in extremely good condition. Really is held a surplus. It's quite a bit higher than is required by law. But again, the trustees have felt very strongly that they sleep a lot better, and as you all do too, that the trust maintains very, very strong reserves, and that's the name of the game. Kempton Premier Providers, which is just our fancy term for medical providers that have chosen to be open and honest with their medical pricing, where we're able to evaluate their pricing on a bundled or unitized basis ahead of time. When we look at that pricing, if it is a very competitive price and they're willing to guarantee the outcome and guarantee that it's an all-inclusive bundle, they go on a list, and then we promote that list to the member banks. And when a member bank participant utilizes one of those providers for one of these services, then it's paid at 100%. We've been doing this since March of 2012. It doesn't seem that long ago to me, but we've been doing this for quite a while. It continues to grow. So far, by June 30 of 2019, Advantage Health Plans has done 969 procedures by utilizing one of these upfront, transparent medical providers. The trust has saved $1.7 million, and where we come up with that savings number is what have we paid historically on average for a given procedure versus how much did we pay for that actual procedure for a particular participant. And we tally those dollars up, those savings numbers up, and we come up with that $1.7 million. When we start looking at the average dollar saved on those almost 1,000 procedures, savings versus the traditional PPO network discount is about $1,759 per claim is being saved. The highest single amount that the trust was able to save on a single procedure was $92,000, which is amazing that you can actually get high quality care and save those kind of dollars off of what we have typically paid for in the past. But that is the largest single. Certainly down from the largest ever. Again, over there on the right, the largest single claim that we've ever seen a savings differential was $153,000. Cash price agreements are continuing to become more and more frequent, and that is where you are the kind of person that will stomp out of a car dealership over $50. You are a Uber consumer, and you find yourself with a procedure that you need to have done, and for whatever reason you choose not to use a premier provider, but you are going to take the pricing that is now available to you because these other providers are transparent. You're going to take that price and you're going to do a one-on-one negotiation with your medical provider that may or may not, probably is not a Kempton Premier provider. And if your negotiation skills are good enough to where you can get your provider to match the price of a premier provider, then the plan will step into your shoes and go ahead and pay that procedure at 100%. I think when we first introduced cash price agreements, we called it kind of consumerism 2.0. It's not for the faint of heart because it's not easy. But Advantage Health Plan Trust members are getting better at it. There's certainly a big easy button, but the whole idea about healthcare transparency and empowering patients with information is they do get the ability to be more active consumers. And so we love to see that number is growing out there.
Can we just go back to the 92,000 saved? I think I just want to kind of underscore for everybody, if we put that in context, that it doesn't take 100% of every procedure that we do or every procedure that every employee and their dependents within your bank that are on your plan. It doesn't take 100% adoption, but you can see from the average amount saved as well as the highest amount saved that even one procedure, what kind of an impact that would have. And so I think that it's important to just kind of think about in the context of where we go from here and what we do next year and how we do better. I think it's important to just kind of understand that the banks that tend to have the most success, the employers that tend to have the most success, they're really adopting a cultural support mechanism around employees that choose to utilize this. But when they do, even if it's not high volume, there could be a real big impact because of the high volume, the high dollars that are at stake, even with one procedure.
Yep, you bet. That's a great point. Okay, so last year, I think we've been doing these slides back to back for a couple of years. I think it's important to see. We do have some missed opportunities. A missed opportunity, these are available. We can provide these on a bank-by-bank basis as long as they're adequately de-identified. But we have had, to the end of June, we've had about 375 missed opportunities. Now, a missed opportunity is classified where we have a participant that has had a procedure done. They have not used a premier provider, but it was available at a premier provider. Like I've said before, this is certainly not like a punishment list or anything else, and this list does not take into account, you may have somebody that had an emergency where time was of the essence. It might have been a procedure that could have been done by a premier provider, but the particular circumstances around this just didn't make sense. It wasn't appropriate to redirect to a premier provider. So of those 375, a few of those could be things where medically it just didn't make sense. Total missed savings dollars, though, we're talking about almost $1.5 million in missed savings opportunities. The average missed savings opportunity was $2,890. From the last slide, our savings was, I think the average was $1,700. The missed is a little bit higher. And I think that may have to do with, some of the things that are more, medically scary, things that are more medically serious. I think people are a little bit more reluctant to say, whoa, let me go ahead and call a patient advocate and see whether or not that can be redirected. That's just a guess. The last item that you see there, though, that largest single claim in 2019 so far that was a missed opportunity was one that is actually it's the new high or the new low, however you want to look at it. The participant actually did cost the bank and the trust $222,000 more by their choice. And this was, unfortunately, fortunately or unfortunately, depending on how you look at it, this was a voluntary and elective procedure. It was of a fairly high magnitude, but it was one of those procedures that, the patient knew that this was going to need to be done for months, if not years. So there was a lot of planning that was done. They actually did call. I think the bank had emphasized, hey, you probably ought to call Advantage Health Plans and talk about this. We did everything we could to try to redirect this. We had multiple premier providers that would do this procedure, but the patient just wanted to stick, just wanted to stay where they're at. I think, no matter how you sliced it, I think they had already met their out-of-pocket maximum, so there wasn't a lot of dollars involved there to the patient. Now to the trust and to the individual bank's experience, that's the difference. That's a big enough deal there. That's the difference between a bank being a bank generating a surplus and a bank costing the trust money. So that could be something, if that bank was large enough, that right there could have resulted in a risk category shift. Again, I think we're all on the same page here. We certainly don't ever want to highlight these things where it's some sort of a punishment or anything like that. But after the fact, when we kind of black box this and we're talking a little bit with the patient on this, the patient's comment was, I had no idea that the differential would be this large. And we did talk to the patient about it, and they had no clue. They just could not believe that the difference between utilizing, a premier provider and then using the facility that they chose, there would be $222,000 worth of difference. And I think that's what we hear a lot of times, that people just don't think that there's that much of a difference. And it's staggering. Some new premier providers, you all probably are seeing emails on a fairly regular basis of these. I'll just kind of quickly read through these. Cleveland Area Hospital up in Cleveland, Oklahoma. That is a rural hospital that is suffering with the plight of most rural hospitals, and that is, how do we keep the doors open? How do we stay relevant? How do we continue to bring value in our communities? And this was a hospital that decided to, the old adage, if you keep doing what you're doing, you're going to get what you've always gotten. It's not going to be good, especially if you're a rural hospital. They decided to step out of the box, and for certain things that they felt like they could do, things like women's health, medical, screenings and physicals and things of that nature, rehab, those were things that they did have the capability of doing. And instead of giving those patients an incentive to leave town, they saw being a premier provider as something that they could give the patient a reason to stay in town. So we applaud hospitals like that. Doctors Outpatient Surgery Center in Lafayette, Louisiana, Zoom Diagnostic Imaging in Enid, that's a good. They didn't have a lot of options up there, so we're happy to see Zoom. Heart of Texas Hospital in Brady, Texas is another really good win that we'll talk a little bit more about in a minute. The Therapy Center in Louisiana is another good multi-location facility. FEM, which is a OBGYN women's health facility in Eunice, Louisiana. That's another kind of broad spectrum premier provider. MotionWorks, another physical therapy, post-surgical physical therapy facility in Chickasha. North Texas Team Care Surgery Center in Mesquite, they are offering a pretty large suite of procedures there in the North Texas area, which is a we really needed some additional options there, so that's a very good one to have. Peak MD, another sleep study provider here in Oklahoma City, and then Saratoga Surgical Center in Corpus. Really happy, really applaud all of these providers for stepping up. The coming soon, though, even though we've got some great things as far as new KPPs, I think the coming soon box are the ones that I'm a little bit more excited about because honestly, we're just talking just between us chickens here. Imaging and physical therapy, if I wanted to add 100 in a year, I could probably do it. I mean, they're relatively easy to get to, become transparent. It's the large ticket items that are really hospital dominated that are more difficult to get a good quality and a good price for. But the three coming soons: Artesian Cancer Center here in Oklahoma City, Oklahoma Cancer Specialists and Research Institute in Tulsa, and then Oklahoma Proton Center, also here in Oklahoma City, are three new KPPs that we have signed agreements with. We're just working to get kind of the logistics worked out. Those are going to be big deals. Those are large ticket. They are, for instance, Oklahoma Cancer Research Institute. That is a joint venture. I liken it. It's similar to Oklahoma Heart. For those of us that are familiar with Oklahoma Heart and Oklahoma City, it's a joint venture between Oklahoma Heart, which is a physician-owned facility, and Mercy Hospital System. Oklahoma Cancer Research is kind of a joint venture. One side of it is physician-owned, and the other side of it is St. John's Health System. So that's an inpatient cancer facility that is very interested in becoming part of this kind of direct to employer space. So very happy about all those things.
It's interesting, Jay, if you look at some of the locations of some of those premier providers, we don't even have clients in some of those locations. Not just on Advantage Health Plans,
not
but
yet.
That's right. But some of those, we don't have any clients in those locations. But I think that's indicative of a culture where the providers are also hungry for adopting contracts with payers and employers through this model. They're looking for something that is different than the traditional insurance branded network contracts. So I think let that just be a little bit of an encouragement to you all as you have these same conversations with providers and others in your own communities.
You bet. These are great points. Yes. That's right. That's absolutely right. Yeah, without a doubt. And we've actually had to do that on a few cases. We before we had a contract with them, we were doing a few just ad hoc one-off. And the patient wanted it. The Proton Center, they wanted it. They had gone out, and we've Proton Therapy is not new. We're familiar with it. But we did find 10 years ago when they first came onto the scene, there was a certain perception. The insurance companies didn't want to pay for it, and Proton Center actually went out of business. They lost their partner. Their partner was Integris. Integris bailed out, and so now they've kind of reopened through new ownership. But we found when we started having patients asking for that type of therapy locally, we found out that in the insurance world, there's a real kind of institutional bias against proton therapy. And as I've talked more and more with friends that are physicians and oncologists, it's like any other business. We don't like to hear it when it comes to our medical care, but it is true. So many medical providers have so much money tied up in traditional, radiation therapies that when a new competitor, even though it might be better, if they don't have one in their basement, they're going to be against it. And they leverage that with the carriers to kill new technologies. And it's hard for us to hear, but it's a reality. It's sad. But anyway, those are good news things. So really, to summarize from the previous slide to where we're going to talk a little bit about reference-based pricing, We've continued to talk about reference-based pricing every year. I hope you all understand that we're not out trying to push it down your throat or sell it or anything like that. But I would say that the number one impediment to cost control or cost containment for any benefit plan right now, and this is an ironic thing to say, but it is an absolute fact, is the PPO networks, the PPO contracts are the largest, they're the biggest impediment for us trying to get good pricing. So again, trying to get to a point where, and what we mean by that is, back on that big missed opportunity where, it was $220,000 more dollars spent. That was a network provider. That was a price that got a I always have to say discount with air quotes. That's with the discount. And there are a lot of networks out there that we see contracts from them on a regular basis that they would actually have prohibited us from even talking to the patient about utilizing the services of a higher quality, lower cost provider, especially if that provider was not in their network. So it's kind of like, it's a headwind that we're always dealing with. The alternative or another strategy besides the PPO network is reference-based pricing. And just otherwise known as Medicare Plus or Medicare reference-based pricing. And just as a quick review, I'm going to pop through a couple of slides. But Advanced Health Plans Trust, we use multiple sources to determine fair and reasonable reimbursements for medical services. We always use a reference price. As bankers, when you all are doing the business of banking, you all always refer to different industry benchmarks to help you make better decisions. Some of the references that Advantage is starting to use, one of the ones that's probably the most predominant is the free market price. In other words, what does a medical provider in an open economy, what would they charge a cash buyer? And so the KPP price is a very good reference. What Medicare pays for a particular medical procedure is another very good, whether you think the government gets it right or the government gets it wrong, they are still the largest buyer of healthcare goods and services in the U.S., and they have put a lot of time, money, and research into coming up with what they feel is reasonable. I don't think anybody would say that it's universally reasonable, but it is certainly a benchmark, and so Medicare can be a reference. Healthcare Blue Book and their fair price, which is kind of a calculation based on different PPO allowables, is also a good reference. Believe it or not, this kind of goes into the free market price, but we use Amazon.com quite often for coming up for, especially for things like durable medical equipment. And it is getting easier, at least for the patients, because we are actively out there. If somebody needs durable medical equipment and they go to their physician, the physician says, well, take this across the street and get this done over there. Don't worry, they're in network. If the patient calls us up and we say, well, the price for that particular piece of durable medical equipment on Amazon is X, go ahead and go across the street and see what the charge is going to be over there, and it might be 10 times the price. But don't worry, you're getting a discount. So we can certainly then advise the patient, why don't you just buy that on Amazon and we'll reimburse you. So we're seeing more and more use of essentially what is just a retail price for things. Again, like I had mentioned before, reference-based pricing, some of the things that it can do over time, we feel, is it does increase overall transparency. Increases provider accountability. It, again, rewards the medical providers that are fair and honest, and it allows the market to work, essentially, by providing more upfront pricing. Increases patient choice and negotiating power. There are a few banks here in the room. One of you I talked to earlier, and I said I wouldn't call you out, and I'm going to keep my promise. But there is a bank, AHP Bank here in the room, that they adopted one of the choice plans, one of the full reference-based pricing plans a year or so ago for all of their employees. It's been working wonderfully for them. And if you ever ask one of those employees, well, who's in your PPO network? Well, the answer is everybody's in my network. I just have to be a smart consumer and be aware ahead of time if it's something that's voluntary and elective. So again, it can increase patient choice. Also, it can reduce or eliminate the PPO networks. PPO networks, if they were doing their job, we wouldn't be so against them. But right now, they don't really know who they work for. Right? There are laws out there, that say you can't work for the buyer and the seller. PPO networks do work for the buyer and the seller, which means that they work for neither. So right now, they're kind of an impediment. Reference-based pricing can help us deleverage and essentially win our independence away from networks. Reduce claims costs, which reduces your contributions. The plans that the banks that are utilizing reference-based pricing, they do perform better. And it's also a sustainable reimbursement model. More and more employers just continue to, as costs go up, they continue to ratchet deductibles up. And, unfortunately, Melissa is just getting ready to roll it out again. It's just, no offense, but, Melissa's going to talk about new plan changes. Well, higher deductible. Help bankers maintain their costs. That's an unsustainable trajectory. At some point, nobody is going to be able to afford their deductible and they're out of pocket. So again, reference-based pricing can assist with that. Just a few more examples, just real quick, before we kind of go to the reference-based pricing metrics. AHP uses reference-based pricing, not necessarily Medicare, but we definitely use a reference on some areas of the plan, and we've done this for a decade plus. Out-of-network, if you go out-of-network, we started indexing out-of-network claims. You don't use a KPP, you don't use a network provider. How are we going to pay that? We used to use what was known as a reasonable and customary charge. Now we just index it to Medicare. If you go out-of-network, we pay physicians' charges at whatever that physician would have gotten paid by Medicare, plus an additional 30%. For out-of-network facilities, it's the Medicare reimbursement plus 60%. For emergency rooms, which, you can't shop for an emergency room if it's an emergency. So we pay whatever that provider would have been paid by Medicare plus an additional 100% for that. I think anesthesiology, we don't have it on the slide, but anesthesiology is what, 230% of Medicare. I think that's right. Implantable devices, as you all know, if you don't use a premier provider, if you use a premier provider, of course, these providers that are premier providers, they include surgical implants as part of their bundle, paid at 100%. But if you don't use a premier provider, AHP, and this is something that your trustees agonized over, it's probably been a decade plus since this decision was made, but we started finding out that when a banker needed to have a pacemaker installed or a rod or a screw in their back, those are widgets, right? They're like the hospital didn't manufacture those. They bought them from a vendor. And then when we started looking at the suggested retail price for some of that hardware versus what this plan was being billed for it, we were seeing markups in the 700 to 1,000% range. And, we were already paying the surgeon, we were already paying the hospital, and those were markups that were just on the hardware. And sometimes the hardware charge was the biggest single part of the bill. So about a decade ago, your board decided, that's got to stop. And that was all allowed by the PPO networks. So we started indexing implantable devices to whatever the medical provider paid for that device. So we were required a purchase invoice, and then we would allow a markup of up to 100% above, guaranteed them 100% return on their money, or the PPO allowable, whichever was less. I'd say 9 times out of 10, 100% markup is less, 100% markup is less than the PPO allowable. So we do hold it to the PPO allowable many times. In interoperative nerve monitoring, we limit that to a flat 4,000. All these are examples of a reference. Are y'all kind of following along here? So when we talk about reference-based pricing, Medicare Plus pricing, I don't want people in the audience to think, oh, that's weird, that's out of the box, I've never heard of that. No, you have. The plan has been using different references to limit benefits to kind of a fair, essentially a non-gouging level. So now that we've been utilizing Medicare Plus reference-based pricing for the choice plans, which some of you all have offered within your bank, and again, all of us have been utilizing reference-based pricing for claims that are out of network. So how's that been working, right? That's the question on everybody's mind. So for 2019, here are some of the metrics so far. We've had 9,112 claims. Now, when we say a claim, we're talking about a claim line. So if you go to the hospital and it ends up being a 20-line bill, every one of those lines is considered a claim here. So we've had 9,100 claims that have been held to a Medicare reference-based price. That has affected 1,867 individual members. So remember, Advantage has 6,000 members, 6,000 belly buttons that are covered under the plan. 1,867 of those individuals have had a claim that has been repriced through some form of Medicare reference-based pricing. Of that 9,000 claims, 67 of them, the provider balance billed. So those Medicare plus 30, Medicare plus 60, Medicare plus 100, only 67 times did the provider come back and say, that's not enough, I'm going to come after the patient with a bill for the difference. As a percentage of the claims with a balanced bill, it's 0.74% of the total reference-based pricing claims. Now, I'm certainly not here to say that for the 67 total bills, it's never a walk in the park. And it's not fun if you're one of those participants that gets a big, scary balance bill. But we also want to keep these things in context here. It is still like we had hoped, our what we thought was going to happen is happening, and that is it is a very, very small amount of the overall claims that get priced on a Medicare Plus type of construct. Of the 67, 29 of those cases have been resolved positively. And I think we talked last year about all of the different balance billing support and advocacy features that are built into the plan, up to and including the FIA group interfacing on the patient's behalf. 29 of those 67, we were able to negotiate a reasonable and rational reimbursement. And so the plan actually did pay a little bit more to get that negotiation with a sign-off that, okay, if we pay a little bit more, will you not go after the patient and accept this as payment in full? And 29 times that did happen. The average amount on a percentage above Medicare that we were able to get acceptance at was 165% of Medicare. That's a good thing, especially when you look at the average PPO, the amount after a PPO discount is somewhere in the neighborhood of 270 to 300% of Medicare. So that's what the medical providers are used to seeing. We were able to get it settled at 165. We look at that as a huge win. We had 2 providers that they just said flat out, no way, no how, we're going after the patient. And then there are 36 that are still in process. And that's going to be just kind of an ongoing deal where you get things resolved and there's going to be claims that are in process that are working. Some of these things do take unfortunately for the patient, they can't get their mind wrapped around why does this take so long. But if it's a hospital, you all probably know, maybe you don't. But hospitals, they will flip one of these bills as they view it as a delinquent bill. They will flip it to their billing department, which ends up usually in South Florida or in Nashville, and it's like dealing with the IRS. It falls into a bureaucracy like none other, and sometimes it's months to get a phone call returned.
I think there is a takeaway here, though, and in this context, and that is that although balance bills are scary sometimes for the participant and even for the bank when you're considering adopting a plan that uses reference-based pricing as the primary pricing mechanism for all claims, the balance billing scenario can be a scary one. But at the same time, when you put it in the context of the overall performance and the number of claims that are running through Advantage Health plans, and then you recognize that the number of balance bills that ever actually materialize is a relatively small number, or not even relatively, it's a really small number. Perhaps that gives you a little bit more comfort. But I think the real takeaway here is that even if a balance bill materializes, and that might happen, that's also not the end of the road for you as the employer, nor for the patient as the person that's the recipient of that balance bill, because there is a robust patient advocacy support infrastructure that's built into Advantage Health plans to assist with that negotiation, and it's proven to be pretty successful, as evidenced by the metrics that we've kind of reported on today. And so if we just kind of are tracking some of the takeaways that we want to take back and that we want you to take back to your places of employment, I think that it would just be continuing to have those conversations. And if your employees do receive a balance bill, there is support, there is help for that, and we're pretty successful at being able to negotiate a reasonable number so that the providers are accepting what the plan is paying, which is overall the intent after all anyway.
In the balance billing support, just as for those of y'all that come to the meeting, we do try to sprinkle a few maybe upcoming things that you may not get an email blast on. And so, what happens at the Skirvin stays at the Skirvin. So if it doesn't happen, that's my disclaimer.
For the webinar participants as well.
That's right. And for the webinar participants. The balance billing support may be getting even more robust here in the future. The FIA group, again, I know we're recording this, but hopefully I disclaimed it. The FIA group is toying with enhancing some of their balance billing support services. Oh, voice, don't leave me now.
That's what you get for bringing this up.
Mm-hmm. Well, the board doesn't even know about it yet, but I think they would want me to use this venue to at least sprinkle it out there. This is kind of a hot off the press deal, but the FIA group, they do a lot of our balance billing support. However, the balance billing support, even though they are a patient advocate in that they are interfacing on behalf of the participant to try to resolve the balance bill, at the end of the day, they are actually working for the plan. They are trying to resolve this in a manner which is in the best interest of the plan. Well, the best interest of the plan is to make sure it has happy bankers. But there is a legal distinction there as far as, you got to know who you work for. Their enhancement that they have talked to us about, and it's not ready for prime time, and it will, Priscilla, it might cost a little bit if we choose to do it. But what it would do, it would essentially at the kind of the end of the balance billing scenario, in other words, if you ended up having some that were unresolved, the plan could pay for and then receive actually an engagement with a law firm that would work on behalf of the patient. So the plan's out of it. So the plan's already paid whatever it's going to pay, and it can't pay any more because it's not a proper expense. But they would go to bat then for the patient directly between the medical provider and the patient, and they would be legally working on behalf of the patient, paid for by the plan. Does that sound like something that would be of interest? I would think so. So again, we're still learning details out on it, and we're still trying to come up with the pricing. But I do think to try to get additional adoption of reference-based pricing, I think you all as bankers, you want to do. And I mean, Melissa and I, we're on the plan as well as the whole Kempton group is. So we're right in here with you. To get additional adoption, we want to do everything we can to make sure that there are many layers of protection for our participants and our employees. But we're not talking about small dollars here. Just on these 9,100 claims, the billed charges were $11.7 million just for those claims. holding them to the reference-based pricing amounts, which again are multiples above what those providers would be paid for by Medicare, which represents the majority of their business. I mean, don't let anybody tell you in the provider community, and we have at least one staring right here in front of me, if you can't keep your doors open at Medicare, you essentially have no hope anyway. And so when you hear from a big hospital, well, we can't make it on Medicare, they're not telling the truth. They can't make tons of money at Medicare, but they've got to be able to at least be as efficient to keep their doors open. So we're really talking about margin here. So even holding it to the allowables that we went over, that brings that 11 million down to $4 million bucks. That's the difference between we could either pay 4 million or we could pay 11 million for those claims. If we're not interested in trying to come up with a fair and reasonable, rational payment method when we deal with medical providers, then we're just going to continue to see this, and it's not going to change. It is not going to change. Okay, so that's kind of over with reference-based pricing. I want to give a few shout-outs here and also emphasize, you all hire the Kempton Group to manage your plan, and also part of what we do, besides paying the claims, provide management assistance, but we're also out there negotiating with medical providers, as you all know. But to a medical provider that doesn't know who we are, they've never done business with us or whatever, they equate Jay Kempton and the Kempton Group, we're just like Aetna, except we're a heck of a lot smaller. Never heard of you guys, but we're the insurance people. And so we're not to be trusted. It's a lot easier to hang up the phone when I call than it is to hang up the phone when a banker from their community calls on behalf of their self-funded health plan. And it changes the entire dynamic. It's not going to keep us from trying to do what we can, and we'll certainly provide the legwork. But boy, an initial interaction, an initial phone call, an initial visit with medical providers in your community can start the conversation. Hey doc, hey hospital administrator, I'm part of this self-funded plan with a bunch of other banks, and boy, we're doing everything we can to provide the best possible benefits we can, have the healthiest employees we can, and you're a big part of that. But man, the pricing that we're seeing from you guys it's tough. It's really hard for us to budget. We have the ability to pay you really quick. We have the ability to waive patients' deductibles and co-insurance and maybe even drive new patients your way. Would you be interested in talking to our administration company that runs our plan for us? That's kind of the way the dialogue might start. I'm going to give a shout out. We've got there's 3 bankers that have done this in 2019 to great effect. We've got one of them here, A.B. Bayouth, past AHP trustee. He has done yeoman's work over it's probably 2018 too. It's been going on for a long time. We bought several key lime pies and lunches and everything else, but it wouldn't happen if it wasn't for AB. He has been reaching out to his local hospital, Bailey Medical, which is actually owned by the St. John's Healthcare System out of Tulsa, but he's got a local branch, if you will, very close to him, and he's been knocking on doors and he's been building relationships, and he finally got us in front of the people that are in charge of contracting for Northeast Oklahoma. And that has finally, after months and months and months, is borne fruit. And we have a direct agreement. It's not implemented yet because it's got to go through legal, and their legal is in Nashville, and it takes forever. But we do have a meeting of the minds as far as what percentage above Medicare that is much, much better than the PPO networks. It's a fair, it's a reasonable price, it's a win-win for everybody. But I'm here to say I could not have gotten it done on my own. I had to have a banker. I had to have somebody that represented the buyer needed to interface. And AB, he kept that ball rolling. Another one that most recently happened is Curtis Armour, Shamrock Bank. He's been interfacing with his hospital in hostile territory down in Durant. That's a tough hospital to do business with, but he's been negotiating with those folks. I don't think we made any breakthroughs there with the hospital, but we have made some breakthroughs with a couple of their surgeons. We're talking with a surgeon down there that is looking very seriously at putting together some bundles, a surgeon-owned transparent pricing, where that surgeon would come up with some medical procedures that he does every day, and he would go out and negotiate with hospitals in his area, with anesthesia groups within his area, see what the best price they could come up with. And if it means using his local hospital, great. If it means using a hospital using the OR that's in another town, he's in it. He's going to put that together. And that wouldn't have happened if it wasn't for Curtis Armour, a banker down there. And then lastly, banker in Brady, Texas, Clay Jones at Commercial National Bank of Brady, started the conversation with his local hospital, Heart of Texas Hospital there in Brady. And now we have a direct, basically 100% payment agreement with Brady Hospital for labs. And Melissa, she's a pretty smooth talker, but she couldn't have gotten that done if it wasn't for the banker. So anyway, just again, I would encourage you all direct negotiating in your community. You don't have to be experts. You don't have to know everything there is to know. It's just, hey, I'm a buyer. These dollars don't come from an insurance company. These dollars come from me, from my bank and other bankers that contribute into a trust fund. And we want to try to get the best deal we can and be really, really good consumers. We want to be a good partner here in our local community. Would you talk to our administrator? So we'd love to do that.
Jay, I might mention too, we assisted several of the bankers that you just mentioned, as well as some others that are currently on the plan, with writing kind of an introductory letter. So if you feel like having a conversation starter would help you to have that conversation with providers in your community, we can provide that letter to you to get started. It's pretty effective. It comes from your point of view, from you being the local person in the community, but just kind of explains a little bit about Advantage Health plans, that we're a self-funded plan, and kind of what we're trying to accomplish by starting those conversations, and of course also introduces us as the administrator. So we can make a note to send that out, and also if you want to enhance it and provide any additional clarity in that letter, relative to your local communities, they're very effective. We've done quite a few of those.
Okay, now I don't know why I get to do the bad news, and I think, Melissa, you get to give away the candy later. But yeah, so 2020 renewal.
By bad news, you mean?
Well, we're talking to bankers here. We are not going to do it. We can't have another rate pass, unfortunately. I wish we could. But the 2020 renewal, we are looking at a 9.88% trust level increase. And again, when we say trust level increase, that doesn't mean that every bank here is going to get that increase. We actually have a distribution slide that we'll see here in a minute. Some banks are going to be paying, well, their increase will be less than that. And as you all know, if your bank is one of these banks that has done things either actively or passively, maybe it's just luck. Good luck is always good. But if your risk has gone down from last year to this year, and it looks like you're going to be a less risky bank as calculated by Milliman, an actuarial firm that we provide data on an ongoing basis to, then you may get a risk category reduction, and where you won't be paying that 9.88, you'll be paying something significantly less than that. Some banks are going to be paying more than the 9.88 if they not only and it kind of works out, as y'all saw in one of the earlier slides, that we're seeing an uptick in claims. That unfortunately, that's not something that happened, across the board. There were some member banks that they had higher claims than, say, their neighbor. And the way that these risk categories are calculated, the banks that contribute more to the larger claims are being asked by their fellow bankers to pick up a bigger piece of the tab, at least for that year. I think Melissa and I were talking about this, and I think it's good to mention this. At Kempton, we got, I think we had a year in between, but right after these risk buckets came on board, we got I think if y'all remember, we all kind of started close to a 0, that middle risk category. We got a shift to the bad shift. And then we didn't move the next year, and then the year after that we got another shift to the bad. And I was wondering if this was such a good idea or not, this risk category deal, because we were certainly on the bad end of it. But we have been able to do some things at Kempton to where we've been able to improve our risk category. We've had 2 risk category reductions, and we're really happy about that. And it's interesting, you see some of the banks that see these risk category reductions, and it seems to be, if you do it once, many times you've done it before. In other words, there's a little bit of a pattern to it, and I think it is, like Melissa said, there's more of that culture of consumerism and making better decisions that's part of it. On ancillary products, which includes dental, there's no rate adjustment at all on any of the ancillary products. We were able to negotiate away any increases on the ancillary products. The dental plan, as y'all may or may not remember, is also self-funded as part of Advanced Health Plans, and Milliman did not make any sort of a recommendation for an increase on the dental plan, so the dental rates are stable. We've also have renegotiated the VSP, the Vision program, for Advanced Health Plans, and been able to get some benefit enhancements there without any increase. So those are some good news things to talk about. Now, as you all know, being a member of Advanced Health Plans is certainly not a year in, year out type of an engagement. If you're here in this room, I know that you all are in it for the long haul, and you know that the board they make decisions to try to do everything they can to create long-term rate stability and clip the peaks and valleys out of things. And so even though we're looking at a slightly larger increase than we've had in past several years, when we look at it on a 5-year run here, in 2016 we had an 8.5, an 8.3 in 17, a 1.5 in 18, a 0 in 19, and then a 9.8 in 2020. Average of 5 years is a 5.64% increase. Melissa, I think you and your team are working with a bank in Texas right now that they're staring at a 55 in 1 year. That's tough. I don't know anybody that can budget for something like that. So again, we wish we had an increase that was close to 0 or negative, because I know you all could always could figure out something to do with that. But overall, I think we are on track as far as the overall management of the plan, keeping things on a budgetable track, and so. Actually, I made a note to myself. I'm glad I did, because I would have forgot. I want to also kind of bring to your attention the role of your fellow banker, your board members, elected board members in this. 2019, as you all saw when we were looking at the net assets available for benefits, they were we were generating more and more surplus. Even when we would put in an increase, even in 2018, we had a 1.5% increase. Not only did that 1.5% increase, not only did it cover the claims for that year and the next year, but we also created more surplus at the same time. And so in 2019, when we had the 0% increase, Milliman, the trust actuary, they actually recommended a rate decrease that year. I hope the board members don't want to strangle me or anything for letting y'all know that, but the board felt it important that this worm is going to turn eventually, and instead of giving the decrease, let's just keep our powder dry. Nobody's going to be mad at us for doing a 0% increase, and when the experience does turn, and it will, and we do have to have an increase. Hopefully it'll be a little bit more manageable. And so again, that's coming from a fellow banker's logic there, and I think they're spot on. So anyway, I think it's important to bring up. Here's the distribution as far as the increases go. This is very close to what we've seen the last several years, which gives us some comfort that Milliman is doing a good job as far as the risk category evaluations. 64% of the member banks are not going to be seeing any sort of a risk shift at all. They're going to stay right where they're at because for the most part, those banks haven't changed from a risk perspective. 19% are going to be moving to a worse risk category, and 17% are going to be moving to a lower risk category. And as we have asterisk there, the letters informing each employer about their individual shift will be provided prior to October 15th, which is the beginning of open enrollment. Okay, so moving on to some plan changes and enhancements. One of the ones that we're really excited to announce here is, has anybody heard of, outside of Advantage Health Plans, just in your own life, heard about a concept known as direct primary care? Yeah.
Some heads nodding.
Yeah, there's a few heads nodding. Yep. It's been on the news quite a bit. If you're plugged in at all, if you're a health care geek or even have any interest in it at all, you've probably have heard it, or it's direct primary care is a big deal, and it's a very, very quickly growing movement across this country, and it really is the independent physician reclaiming their role and their relevance in their patients' lives is what it is really about. It has the opportunity to strengthen and enhance the doctor-patient relationship, which is going to ultimately end in better health management to its patients, and this is where Advantage Health Plan's interest comes in. If we have better doctor-patient relationships, we have better health management, we're hopefully going to have lower cost. And so that's why your board, again, really being on the cutting edge here. When we brought to them the whole concept of premier providers years ago, nobody else was doing this. I think we're probably the first health plan in Oklahoma that is integrated a direct primary care benefit right into the health plan. It's not an add-on. It's actually a benefit under the terms of the plan. We're going to have a physician here. Dr. Kyle Rickner is going to come up here, or he's going to grab a mic and kind of talk about direct primary care real quick. And then Melissa's going to talk about how this benefit works within Advantage Health Plans. But this is probably one of the most exciting things that we've been involved with, and we're very, very optimistic that as this grows, you're going to see some, I alluded to Kempton getting a couple of bucket to the good shifts. We've been doing direct primary care within the Kempton Group, my 50 employees now, for about 5 years. Not through Advantage Health Plans, just right out of my pocket, right out of the Kempton Group's pocket. So we're believers in it, and we think it can do for what it's done for the Kempton Group. We think it can do it also for Advantage Health Plans. With all that being said, I'm going to turn it over to Dr. Kyle Rickner with Primary Health Partners.
All right. Thank you, Jay. I appreciate that, and I like to get up and be the bearer of good news instead of bad news. And as Jay alluded to, one of the advantages to involving direct primary care in a self-funded plan is hopefully to help the overall reduction of that increase. There's a lot of evidence from that around the country when direct primary care has been involved with employers. And what we're doing here, what we've been working on for almost a year together, is integrating this into a health plan. And we're not sure this has been done like this anywhere in the United States. So it's exciting to be part of this innovation and bringing it to Advantage Health Plan Trust, and we appreciate the opportunity to do this. Today I'm going to introduce you to a little bit of the nuts and bolts about what direct primary care is, who we are at Primary Health Partners, And hopefully there'll be an expansion in the future of the number of providers that this involves. Before I get into all that, I'm going to stop and take a second. And I know in the busyness of our lives, we have our to-do list and things to do. But I hope each of us, either collectively or individually, just stopped for a moment today and remembered what the significance of this day was. It was a tragic day in our history. It changed many of our lives forever, mine included directly. 2,996 people lost their lives on this day 18 years ago. And they have a new monument in New York City that has actually been released. And I don't have the number of deaths, but it's the deaths of people that suffered illnesses related to that day that they've begun tracking. And so the death toll continues to rise. So it's a significant day. I don't want us to go about our business and forget how fortunate we are to live here. If any of you have traveled to New York and seen the monument and what took place at Ground Zero and what they've built up, it's amazing. We're blessed to live in the greatest country on earth. And so I just wanted to mention that. So direct primary care is a model of care that is built around the doctor-patient relationship. That is exactly the thing that the fee-for-service world has stolen from us. I've worked in multiple settings. I've delivered primary care in multiple different models. And the one thing that kept being eroded, no matter what that model was my time with the patient and the patient's access to me. And so direct primary care is actually the remedy for that. I'm very passionate about this because I believe we're part of the solution or the fix to the frustration of healthcare, both on the cost side, but on the delivery of care side that all of us have probably experienced at some point. So it is relationship-based medicine. We make it our business to get to know our patients. One thing that's not included in this slide set that's very important, and the reason that this works the way it does, is we have a limited number of patients that we take care of. So primary health partners, our full providers, will have between 600 and 800 patients. When I was in the fee-for-service world, I had about 3,500. It's really not possible to get to know everybody when you have that many on that level. But the people I have now, I know them, I know their story. It makes it much easier to take care of them. The payment model is simple. It's a flat monthly fee. It's like joining the gym. Essentially, you can go in and use all the equipment you want. You're not charged for the treadmill or the weights or any of the cardio equipment, and that's kind of how this works. It's paid for by the plan for the employees, Advantage Health Plan. We don't have any visit fees when you come to the office or when you access care. The other thing that this frees up that I want to expand on when it says unrestricted access to primary care, we leverage technology to provide that access. So if anything, it's that we offer almost too many ways to get into contact with us, but I was taking care of patients sitting right here. And as I got here today, one of my patients that has temporarily moved to California, I did a virtual visit with him in the lobby of the Skirvin and got him taken care of. So it shrinks the miles. And when we were in the board meeting almost a year ago, one of the board members that lives out a ways in Oklahoma brought up the fact that he sort of clicked with this and said, well, if I have to make one trip to Oklahoma City a year, and then the rest of the year I can actually, that's better than what I have now. And so he's true. That leveraging technology shrinks the miles. And really we get healthier, happier employees, because if you're sick right now and you have to leave and go to the doctor, that's usually not something people look forward to. It's usually not an efficient process. It's just a frustration. So what happens? You get employees that show up to work sick and they don't go to the doctor and they get everybody else sick. It's a detriment to the workplace, but they don't want to take the half a day off that they often have to do. So in some of the more common things, we can be leveraged by email or by phone or by text or by virtual visit like I did today. Get the patient taken care of. They don't necessarily have to leave the workplace, or they can access care on same day and get in and get out and get back to the workplace. So we increase presenteeism and decrease absenteeism in the workplace. So next slide, please. So this is just the list of things that are covered typically in primary care. There's really not any uncovered entities in our offices. So there's no other professional billing that takes place. You know, that the old adage of the more I do, the more I get paid, and that way of doing things, and you as lay people not knowing actually what you really need and what you don't really need, and there's a high trust factor. But the physician or the providers on the other side of that absolutely knowing that their bottom line gets affected depending on what they do and don't do for you. And that is a tension that frankly I got exhausted by living in. And I didn't like that. It was rotating in my brain all the time. I don't have to think about that anymore. All I think about is absolutely what's best for our patients. You can always do the right thing. The payment incentives are gone in terms of that. So, and because we have a limited number of patients per provider, we're not in this race through time. Our newest provider that will be joining us here in a few weeks when our Moore Clinic opens, I'll show pictures of all our providers, but Dr. Louis Wall, he was sharing with some employers the other day at a meeting I was at with him that he knows that his average interaction time with his patient now is down to 7 minutes. That's what he gets. And so often you guys have experienced the frustration of, I'm coming in for this, and oh, by the way, I forgot. I also have another appointment. You know, they stop you. We don't do that. We just take care of what needs to be done there the vast majority of the time. We don't charge for procedures or testing, anything that we can do in the office for you. One thing that's not mentioned on there that I think is very valuable, a line that I tell my patients when they come in as a new patient is if you ever go to an urgent care, it's a personal insult to me because there's nothing that's going to occur in there that we can't take care of. So we have patients that may get quite ill and they are having troubles and they might need some IV fluids or something. We bring them in, we just do the IV fluids in the office and get them squared away, and we don't charge for that. So I found out through doing that for a patient when I had a student who happened to be in charge of putting in charges for one of the health systems that will remain unnamed, that when he observed me doing that and he asked me what I charged and I said nothing, he said, how possibly can you do that? And I knew at that time that I could purchase a bag of fluid. My cost was $7.32 for a bag of fluid. And so he proceeded to tell me their charges for a bag of fluid at the health system was $300, and they charged $120 an hour infusion rate. So that, I'm not sure how you sleep at night doing that, but if I can buy it for $732, I wonder what they can buy it for. So that the 1,000% markup stuff that Jay alerted to earlier is true. Next slide, please. I've already mentioned it's 24/7 access. We do not have call groups, and we do not have nurses lines or answering services. I have my cell phone, and if a patient texts me after hours or calls me, it goes straight to me. And occasionally, I mean, we like to leave town sometimes, and if it's in a place where I don't have coverage, I may have a partner take those calls. I mean, we're human too, but really, on a regular basis, we're able to take care of people after hours and on weekends. Because we have a limited number of patients in our panels, our accesses go up. So oftentimes, if it's something that's urgent, it's a same day thing that we can do, or next day perhaps. And so there's none of this, well, I'm sick, well, we can see you a week from Thursday kind of thing. That just doesn't happen. One of the things that we do that is particularly important when you start talking about Advantage Health Plans Trust or any self-funded plan is we become a cost-conscious advocate for the patient, but also for the plan. And it's a very unique relationship and space that we get to live in. And everybody wins. So we try to see what services can we provide, what things can we do that bring an advantage that is absolutely patient-centered, but also plan-friendly, okay? Two examples that are listed up here, lab work and medications. So we maintain a client-based lab contract. So the prices that we get for cost of labs are way less than anything you've ever seen. because the cost of doing the labs are super, super cheap in reality. And guess what? They don't do that for us because they're kind and they just want to be benevolent to the community. They make money off my cheap little prices. Well, we don't mark anything up to make money off that. So we just pass that on to the lab, to the patient. So for example, a gentleman that I was seeing this morning who's actually a retired professor and has a very robust health plan behind his Medicare, so nothing costs him anything hardly. And I told him as we were going to do his wellness panel of labs this morning that the entire cost was $34. He started laughing and he said, I'll just pay it. And he didn't want to mess with EOBs coming in the mail later or anything like that. So, we actually have about 18% of our patients are Medicare, and about 90% of those actually choose to just pay for the labs themselves because they're just so cheap. So, and it's very, very convenient. So it's right at the time of service. No bill ends up in anybody's box later. So however many patients end up taking advantage of this, those are bills that the $34 I just told you, on average, billed to a health plan will be $350 to $400. So if plan beneficiaries take advantage of that and they say, you know what, I'll just pay the $30, the plan just saved $400 perhaps. So you start extrapolating that and you can see why it's very friendly to the plan. The other thing we do is we have pharmacies in our clinics. These are not full pharmacies. We're not CVS and Walgreens, but we carry about 100 products and everything is generic. So we cannot cover everything, but we cover about 77% of prescriptive needs. And we do that with chronic medications as well as acute care medications. So if you come in and you're sick and you need an antibiotic, you usually are walking out with that. Well, we're able to do the same thing cost-wise with those medications that we do with the lab. We actually order them and stock them from a wholesaler and do not mark them up to make any profit. So they're ridiculously cheap. So plan beneficiaries that may have a minimum copay on a generic, most of the time our medicine's going to be less than that. So, and there's examples on our website that you can look at and things. There's several, but blood pressure medicine, lisinopril, for example, on the chronic side, I know a 3-month supply of that right now in our office is $4.05 for 3 months. If you need a Z-Pak antibiotic, that's right about $5. It's not worth using the plan. So then all of a sudden there's prescriptive claims that don't hit the plan as well. And the patient benefits because they don't even have to go to the pharmacy. They just leave the office with money. So we try to help in those kind of ways as well. So we do not charge for any services that we render, whether it's nurse or physician within the office. We try to bring in things that are very cost effective. If you need an EKG, we just do it. It's not expensive for me to do an EKG. If you need strep test, we just do it. It's not expensive. We don't charge you. And if we actually bring in some other services like spirometry, which are breathing tests, and we just do it. We don't charge. So it does cover a lot. The other downstream benefit of this that I found after being a physician in practice for 20 years, another student that was with me for a while was a very quiet lady. And after being with me a couple of weeks, she hadn't said much. And I said, do you have any questions for me at all? She goes, yeah, I do. She goes, do you ever refer anybody? And I thought about it. I was like, I refer a lot less because I actually have time. In my other workaday world, seeing 27 to 30 a day, I had the expertise and I had the knowledge, but I didn't have the time to do a lot. So what did I have to do? I had to kick the can down the road to a specialist. Costs go up. So I'm able to do a lot of stuff in the office that I wouldn't have done before just because.
The employer enjoyed that too.
Well, that was the whole idea, Jay. Keep me very busy, so I kicked as many cans down the road as possible. We take great pride in not kicking cans down the road. So, and if you come in as a patient to us and you see the cardiologist for your blood pressure and you see the podiatrist for your toenails and you go to the dermatologist for your skin, we're probably going to encourage you not to go to all those visits, that we can handle all of that. But at the same time, we use our judgment, and if specialty care is needed, we are case managers on steroids. We've made it our business to know your business. And so we know how to leverage plans. We know how to leverage cost. We know who the other providers are in town. And even with the Kempton Preferred Provider Network, normally that's a process that may have to be handled administratively. I mean, we actually as providers can just pick up the phone and call and just get it done. So it really is nice being the patient's advocate with everything. Next slide. This is who we are. Myself and two other physicians, Katrina Bourne and Robert Lockwood, are in Yukon. That's our original clinic. And then our clinic in Edmond, which is on South Boulevard, with Dr. Mindy Kale. I don't know if you guys listen to KISS FM in the mornings on Wednesday, like this morning. Dr. Mindy, that's her. She's also on News Channel 4 on Thursday afternoons. So, and then Dr. Trey Kale. They are not husband and wife. They're actually brother and sister. And then Michelle Merrill's our nurse practitioner there. Edmond, they've started, they offer some additional services. We had Michelle trained to do, because we had patients that were requesting and going elsewhere for these services of like hormone pellets and hormone therapy, and that cost a ton of money. So we said, you know what, let's just do it, and let's do it at cost almost. You know, we want to make sure Michelle gets, so what we do it for our members is about less than half of what is paid on the outside. So she does that in Edmond, and they also run a weight loss clinic in Edmond that is free to the members, and they offer different avenues for that. So, and then our clinic that opened in January in Northwest Oklahoma City, right near the spine hospitals where that's at, and we've got Dr. Krista Schwartz there, and actually Dr. Mike Eskew, he's a nurse practitioner, but he has a doctorate from Duke, so he's a super sharp guy. I've known Mike for a long time. And then more clinic that we're very excited that will be opening here in just a few weeks. That Magnolia Court is actually a new street, but it's on just south of 19th Street on Telephone Road. We've got Dr. Louis Wall and Christy, a PA that's been with him for 8 years. So that's who we are now. We have room to grow. This is who you can access right now under your benefit. When you go and sign in page 17 and 18 of your booklet, there is a great description about how, sort of what I've summarized, it puts it into bullet points, and then there's also instructions on how you would enroll. And so, and I'm going to stick around, and I know there's questions at the end, and if there's any particular questions related to this, I'll be happy to take them. And I'm also going to hang around afterwards, so if you have specific questions, because the goal of me being here is to make sure you know everything you need to know about this benefit. And once you do that, it's really foolish for people not to sign up. All right?
Thank you, Doctor. And he's also going to be here on Friday morning for a breakout for non-Advantage Health Plans members. So thank you, Doctor. Melissa?
Yep. So now that hopefully you kind of understand a little bit about direct primary care and the care delivery model, we need to talk about the benefit that is going to be kind of wrapped around that care delivery model and what that will look like within Advantage Health Plans. I do think it's important to say, and I think that Dr. Rickner, thank you for saying this as well, you know, embedding this type of a benefit into a health plan is a pretty progressive approach. One that has been supported and we think that we will see returns on, you know, many times over, but it is a progressive approach. And so having said that, it's also important to say that, you know, Primary Health Partners has been a real partner in the true sense of the word in developing this benefit and getting this off the ground in its pilot phase, which is what we're in the midst of right now. We're thinking that, you know, given the number of enrollments that we have currently and what we're projecting as a result of this meeting and open enrollment this year, we're thinking that probably the pilot phase will probably continue through the end of the year. But we have every expectation that beginning in the beginning of 2020, we would be not only enhancing the benefit, but also bringing on additional direct primary care providers through this benefit. So I guess you could say a DPC practice through the benefit that we're offering with Advantage Health Plans is coming soon to you, but just kind of put this in the context of what you saw evolve over the last several years also with the KPP free program. And that is, it started with one provider back in 2012, and it has now grown to over 100 some odd providers. And so we fully expect that you will see this grow as well. If you're curious, and I don't know, Jay, if we want to pull it up now or we can maybe look at that later, but if you're curious about where direct primary care docs are in the landscape of Texas, Oklahoma, New Mexico, et cetera, there's a nice tool that's publicly available that you can use. It's not a tool that is sourced by us, but it is a tool that can be a resource for you to identify what direct primary care doctors exist out in the world. DPC Mapper has a nice search functionality that you can see what providers in particular geographical areas participate in this type of a model.
And I think it's important, though, with that being said, that there is no such thing as a DPC, direct primary care network. DPCs aren't owned by anybody, and that's kind of the point. Every one DPC is not like the other DPC. This is very much of a free market approach. Primary Health Partners has their model that they've built, and they're really, really good at it. But there are other direct primary care physicians. If we get this thing to pull up, I'll just have to wait a second. But we get this to pull up, I'll show you. There are DPC providers all over Oklahoma, all over Texas, all over New Mexico, all over this country. And they're popping up more and more every day. These are not docs that are just coming out of med school and saying, well, I can't make it in a real job, so I'm going to be a DPC. These are physicians that are employed now that are saying, I'm either getting out of medicine because I've had it, I'm just up to here with the way things are done. That's generally where these folks are coming from. I mean, Dr. Reitner, that's your story. That's really it. So, yeah, so this is... That's where the DPCs are located here in the U.S., and this is about as grassroots as you can possibly get. I could see a few years ago that this was, my goodness, there weren't nearly as many dots on this. It's gone crazy in a short amount of time. I really think it's the future.
Okay, so the name of the benefit that we are embedding into the health plan, again, just kind of putting it in the context of other benefits that you're familiar with. The name of the enhanced benefit that we have available with bundled cash price providers is KPP free, Kempton Premier Providers. Similarly, the name of the benefit that we're wrapping around the DPC, direct primary care model, is Kempton Direct Access Providers. We lovingly refer to it around our office, and you probably will hear us using the acronym and slip and say KDAP, but that stands for Kempton Direct Access Providers. What that means is the benefit to be able to access the direct primary care through a DPC provider at Primary Health Partners practice. So what that benefit is essentially going to cover is under the plan without an additional expense to the participant, as well without an additional expense to the employer that participates in Advantage Health Plans, is the monthly fee that is paid to Primary Health Partners on behalf of the participant to be able to access and have all of the services that Dr. Reitner just talked about covered under that service. The monthly fee that is going to be covered by the plan is up to $70 per month. Now, just to put that in context, oftentimes direct primary care providers will sort of tier their enrollment fee. They'll tier their member service monthly fee based on perhaps age. Through this model, the fee has kind of been set for the participants of Advantage Health Plans to be a flat amount, and so that $70 amount that is covered under the plan will actually cover 100% of the fee that ends up being charged by Primary Health Partners in most cases. If the participant is intending upon enrolling, they must be an employee of the participating employer that participates on the plan. So this benefit right now, and it's again in its pilot stage, it is intended to be for employees only. So Jay mentioned earlier that we at the Kempton Group have adopted this type of a model for employees of the Kempton Group. I myself am a participant of a DPC practice in Texas as well as my husband does. But for right now, the subsidy that's going to be available and be paid as a benefit under Advantage Health Plans is going to be for participating employees of participating employers of the health plan.
And I think I might interject there just so y'all can kind of get your mind wrapped around this. The $70, Melissa used the term subsidy. And that is, I think, a key term that you'll need to kind of keep in your mind here, that this Advantage Health Plans is, we are not providing direct primary care benefits. We are providing Advantage Health Plans is providing a subsidy under the plan, so a participant can go out and get their own direct primary care relationship. Okay, you don't have to do that. You don't have to take advantage of that benefit. You don't have to change your doctor. You can just keep on doing exactly what you're doing today. This is just think of it this way, there's $70 per month available to the employees right now of Advantage Health Plans if they choose to go out and enroll with a Kempton Direct Access provider, which right now is Primary Health Partners, but soon will expand. Now, to kind of fast forward, 10 years from now, or 5 years from now, it might be a lot quicker than we think. Ideally, the health plan, honestly, folks, the health plan shouldn't be part of this at all. Ideally, I think the vision here, I don't know if we'll ever get here. I don't know if the law will let us get here. But ideally, it would be a situation in which each and every one of us, we just voluntarily choose to have our own direct primary care relationship that we pay out of our own pocket. It's our relationship. We pay it out of our own pocket because it's saved the health plan so darn much money that it's reduced the cost of the health plan so much that the banks can afford to give you a bonus or raise your pay so you can go out and afford your own DPC membership and cut the health plan out of it, where the health plan is not even part of we don't even have primary care other than what the Affordable Care Act requires us to do. But does that kind of make sense to everybody? That's kind of the long game. Again, we may not ever get there, but ideally, if you all believe that direct primary care is the best thing for you, but your direct primary care person that's in Austin, Texas is not a KDAP right now, well, I can't get the $70, but I think this would be a great thing for me and my family. Go out and sign up with that direct primary care physician. It'll be out of your own pocket. But that's what we did at Kempton long before Advantage Health Plans was ever providing a subsidy. Kempton Group, we decided we believe in this. We think this is going to improve our bucket. And so we made a contribution to a health reimbursement account on behalf of our employees to go out and sign up their own direct primary care physician. And about 2/3 of my employees ultimately did that. So the health plan really didn't need to be involved. The reason the health plan is involved and is providing the $70 a month subsidy is because we're trying to kickstart a movement here. So I want y'all to kind of understand the rationale behind this, because I think if we roll this out to employees are going to say, well, what in the world what do I have on my doctor's office copay for right now? I only have to pay $40 when I go see a doc, and you're asking me to pay $70 a month even when I don't see the doc? I don't know that a lot of employees, at least right now today, would think that was a good deal. And so the board felt like, well, if we need to kind of prime this pump here. So we think it's in the best interest in the long game for reducing upstream medical costs. We think it is important that we can supply a $70 subsidy for a person to then go out and then they can engage with a direct primary care physician at no cost, at least initially. So anyway, sorry to steal your thunder. I just want to get some context to the rationale here.
Are we going to get to where we can find those primary care providers in our community and submit them for review to be? Because I know who one of these is in our community. I don't know if it was Coleman or if it was David, but when Kempton did this, they told me about it.
Yep.
And said y'all were paying it. And we talked about it because I thought, what a neat idea, but additional cost to the bank. So we
Yep. Well, and the answer to that is yes, but if you submit it, we're just going to put it in a tickler file and then follow up with them in the future. We've been fielding a lot of those because word has gotten out. The direct primary care physicians, they talk. They're a community just like community bankers, and so our phone's been ringing a lot. They're saying, we want to sign up. We want to be a Kempton Direct Access. Of course, they didn't call it a Kempton Direct Access provider because that term hadn't even been invented yet, and we didn't even know what signing up meant. There's actually some technology that's going back and forth, so when somebody goes out, they can actually sign up. We can verify that the person's actually getting the service because there's some compliance questions that have got to be answered. So there are some things that are happening behind the scenes that we didn't have anybody to model it after. We, like Dr. Rickner said, we literally invented this. And Maria did a lot of the work on this, and other attorneys have been working on how do we make sure that because we are using plan assets for this, and direct primary care until very recently was considered incorrectly. It was considered like a health club membership, and was not an allowable expense. It now is. So anyway, the answer to your question is send them to us, but don't have your feelings hurt if we don't sign them up immediately. We're going to start going out and signing more and more providers up to do this in areas all over AHP's market after January 1.
Well, due to us being, an hour and a half away, and a good percentage of our employees being in that area, we do have employees in Tulsa and Oklahoma City as well. But it would help us to have someone locally.
You bet, absolutely, and that is not lost on us at all. Again, like Kempton Premier Providers, again, we weren't this is something that had never been done before, and so having a willing partner to develop this was always important, and it just so happens that Oklahoma City is kind of the nexus of that, but we're going to try to spread it as fast as we can.
Oh, we're excited. We have employees in Oklahoma City.
Great.
We'll be letting them know.
Well, there are a couple of requirements that we should probably talk about, not because they're intended to be an imposition in the model that we just articulated, but at the same time, in order to achieve the maximum effectiveness of the relationship that will exist between the doctor and the patient, we did feel like that the health plan needed to make sure that the participant was utilizing the enrollment in that DPC model. The way that the health plan will ensure that the participant is utilizing it, there's a couple of requirements. One is that once the participant does enroll in the KDAP program, which there's some information Dr. Richter mentioned that is in your packet here on how to enroll. We've also got tons of educational material to help both you at the employer level as well as at the employee level understand how to get through that enrollment, some that we don't have time to go through here today. But once the participant does enroll, then there's a requirement that the participant does get in to see the DPC, the KDAP provider, within the first 6 months. And it's the intention of that initial visit to be a health risk assessment, kind of to set the foundation for the doctor-patient relationship on a go-forward basis. Additionally, there is a requirement for continued participation that the participant does engage in at least one visit on an annual basis with that KDAP provider as well.
And that helps us with compliance as well, to make sure that this is not a benefit that is not being, the plan assets are not being expended for no value to the plan.
Sure. And then the other thing that I might mention that's probably important for any of the employers that have elected to offer a qualified high deductible health plan, and by qualified what we mean by that is that it is eligible to be paired with a health savings account or HSA. There are some limitations that the IRS places on those types of health plans. One of those limitations is that the participant that's enrolled in that type of health plan is not eligible for any benefits other than preventive services prior to the deductible being met. If you're offering one of those plans, you're probably very familiar with those types of limitations, because we also have some limitations that are placed on the utilization of the Kempton Premier Provider Program for those participants in those plans. The same limitation exists on the KDAP program. The Kempton Direct Access Providers currently is not eligible for members that are enrolled in one of those qualified HDHP health plans. That's a compliance thing that doesn't have anything to do with Kempton or an imposition of Advantage Health plans as well. well, that is strictly to maintain compliance with that qualified high deductible health plan for its compatibility with a health savings account. Her question was, could the employer pay that $70 of a subsidy to primary health partners?
I would say no. You can't pay it to primary health partners, but you can do it through payroll.
So it's a more complex answer, and,
Yeah.
and part of the reason that he's saying through payroll is because again, that type of a plan design, there are limitations that are placed on not only the benefits that are offered by the plan, but the IRS kind of took some liberties and imposed some limitations on any other benefit that the employee might be enrolled in, this being one of them, telemedicine being one of them. There's lots of compliance chains that the IRS puts on participation when you're in an HDHP plan. And so there are some creative ways to ensure that you are in compliance, but paying for that subsidy outright is not one of those ways.
I will say on that DPC mapper, all those dots, those DPCs are pretty vocal and they're pretty effective communicators with their politicians. And they're working very, very diligently to remove that HSA qualified high deductible health plan limitation. It hasn't happened yet, but they are tenacious.
It's all good questions. We may have some time for some more questions at the conclusion. I do want to talk us through a couple of other additional plan changes if we want to kind of move there. Some additional plan enhancements that we have coming January 1st, 2020. Some of you all may not even be familiar with this limitation. It's certainly not one that we probably talk about in the employee meetings on a regular basis, but it is kind of what we would put under the category of a legacy benefit that has kind of always existed under Advantage Health Plans, and it is time for an upgrade. So essentially, the first plan enhancement that you all will see is that traditionally, or historically, I should say, any inpatient room and board claims that were received by Advantage Health Plans had a limited benefit, limiting the reimbursement to that provider for those inpatient room and board claims to the semi-private room rate. So essentially, whatever was billed on that claim for inpatient room and board, the maximum reimbursement that could be given was based on the semi-private room rate. And there's a difference between the semi-private room rate and the private room rate. We've essentially, starting 2020, we've removed that limitation, and we're just going to hold, the plan will hold any of the reimbursements for inpatient room and board to whatever the PPO negotiated rate is, the PPO negotiated allowable, or Medicare reference-based pricing if it's an out-of-network provider or it's somebody that's participating in the choice plan. This is truly an enhancement. Honestly, many of you may not even been aware that limitation existed. In the case that a participant might have received a balance bill, if that occurred, then that would where you would see this impact your participants, because likely that would go away at this point.
If my kids were in this room right now, they'd be saying, what's a semi-private room?
They don't exist.
That's what we said. It's a very legacy provision, so it's going away.
The second plan enhancement is something that perhaps more individuals might be familiar with. The plan after a mastectomy does cover a breast reconstruction and has. That is a requirement. It is something that the plan has always been compliant with. But there have been some questions and really some evolutions of the practice probably over the last several years to be able to complete a reconstruction on a breast not only after a mastectomy but also after a lumpectomy. There is a different type of tissue reconstruction with or without implant, depending on the type of and the amount of tissue that has been removed. There historically could have been some scenarios where a reconstruction might have been limited if the amount of tissue that had been removed prior did not reach that threshold. So the enhancement that is being made to the plan is that the reconstruction will now be covered whether it is a full mastectomy or a partial mastectomy or lumpectomy. The next two plan changes that we'll talk about, primarily these are in the category of compliance. You probably recall that these happened over the last couple of years just as a result of the Affordable Care Act. On the first plan change, for any of the employers that are enrolled or have elected to offer the high deductible health plan, which you all know that we actually have two of those, there are some maximums that are imposed on those plans per the Affordable Care Act, and we need to raise those maximums in order to stay compliant with those requirements. So the current family or embedded deductible for an individual that is a participant in a family tier on a high deductible health plan is $2,700, and that needs to increase for 2020 up to $2,800. The other one is on our MVP, which that stands for the minimum value plan. So you all may remember that for employers that are considered an applicable large employer required to comply with the regulations of the Affordable Care Act by offering a certain type of plan design in order to, ensure its affordability and that it covers all the benefits that are required and stay out of the penalty box under the Affordable Care Act, we created a plan design to meet those requirements. That plan design had the least amount of benefits. Everything was pared down to kind of the minimum threshold of compliance through the Affordable Care Act, and therefore we called them the minimum value plan. So an employer could stay compliant, but shave benefits and also shave premium to be able to stay affordable at the same time. Those plan designs also track maximum out-of-pocket requirements under the Affordable Care Act, and so we need to evolve with those requirements that occur every year. And so the current maximum on both the MVP standard plan as well as the MVP plus plan is $7,900 for a single enrollment and $15,800 for a family, and those will be increasing starting January 1st, 2020, required by the Affordable Care Act, to $8,150 for a single and $16,300 for a family enrollment. Jay mentioned a little bit earlier that we were going to be creating or adding a couple of additional plans in the interest of providing what we call a migration path for employers that are kind of looking for a way. If you are looking at that 9.88% rate increase that we talked about earlier, if you're looking for a way to kind of mitigate that, there are some ways to do that. One of the ways to do that is to kind of look at the plan design that you're offering. One of the ways to do that is to look at some alternate plan designs that might be available, which we can talk with you about. But if you've kind of gone through that migration path and you are an employer that is currently adopting or currently offering one of the value plans, which have a $2,000 deductible or a $3,000 deductible, then the leap between where you're at today on those value plans to the next available plan design was a little bit of a leap. And it was a little bit of a leap in the form of higher deductibles. So essentially the two plan designs that we have created and will be offering starting in January are kind of designed to bridge the gap between where you might be at today and where the other available plans were. You all are familiar with the type of plan designs and kind of the different structures that we offer. We've got select plans, we've got value plans, minimum value plans. If you're offering those value plans today, you're kind of familiar that the name of the plan tracks whatever the amount of the deductible is. So on those value 3,000 or value 2,000 plans, that 2,000 or 3,000 name is what indicates what the level of the deductible is for that plan design. Those value plans also have a 70-30% coinsurance. And then they also have a little bit different copay structure depending on if you're comparing those to the select plan. So these two plan designs that we're showing here, both the value 3,500 as well as the value 5,000 plan, these are going to mirror, for all intents and purposes, they're going to mirror the value plan designs that exist today, with the exception that we've increased the deductible. We're offering one plan design that has a $3,500 deductible and a second plan design that has a $5,000 deductible. They will still maintain the 70-30 coinsurance. They will still maintain the same copay structure as the other value plans that we offer. So you're familiar that the primary care and specialist copay for office visits and for urgent care is $35 on those value plans, and that will be the same on these two plan designs that will be available. And additionally, the pharmacy copay for generic as well as brand name copays will also remain the same. So it just all of the same plan design, all of the same benefits, all of the same coverage and exclusions, all of the limitations, everything is going to be exactly the same as the other value plans, with the exception that we've increased the deductibles a little bit on these plans so that there's a little bit of a bridge to get you if you need some assistance with some premium relief at your renewal.
Great.
Couple of other plan design changes. Some of you are probably already familiar with some of these. First of all, many of you know that the Community Bankers Association of Oklahoma endorses a telemedicine product, Teladoc. The Independent Bankers Association of Texas, IBAT, endorses a telemedicine product, My Telemedicine. Telemedicine is becoming a popular service that is offered by employers to their employees. But there are some compliance hurdles to jump over from the employer's perspective when you offer a telemedicine program. Some that you may not have been aware of. But one that we are aware of. And so this plan change, it's really not even a plan change. It's really assistance that we at Advantage Health Plans and at the Kempton Group are offering to the employers who are participants of Advantage Health Plans to help you bridge your compliance gap. So telemedicine, just kind of in summary, telemedicine actually is subject to the requirements of the Affordable Care Act, to HIPAA, and to ERISA. And on its own, outside of a health plan, if the employer is offering telemedicine, it's not compliant with those regulations.
They view it as a health plan, believe it or not. And if it's a health plan, then it's got to have a plan document. It's got to have all of the things that a regular old health plan has. And I think a lot of bankers they're just not aware of it. Nobody told them. Teladoc didn't tell you. My Telemedicine didn't tell you. And but it was a gap that we identified, and I think we've got it filled.
Yeah. So the way this change works is there's not really been a change to the health plan. The only change is that by attaching telemedicine to Advantage Health Plans, which will be an allowable benefit under the plan, so if the employer elects it, our plan under Advantage Health Plans is compliant with ERISA and the ACA and HIPAA. So by attaching the telemedicine benefit to Advantage Health Plans, de facto, the telemedicine program also becomes compliant. So all that would be required for an employer, if the employer is currently offering a telemedicine program, then it's basically paperwork. It's administrative, because now it is compliant effective 7/1 of this year. So we will help you with that. Additionally, if the employer is interested in offering a telemedicine benefit, then you have the ability to do it and to make sure that you're compliant, and we can assist you with offering that. That telemedicine benefit, I probably should mention that is not a fee that is covered by Advantage Health Plans. That is an additional fee that is if you're offering as the employer a telemedicine benefit, then there's a nominal fee per employee per month that you're paying on behalf of your employees to be able to access that benefit.
That's between the bank and the telemedicine provider. This is simply a check-the-box compliance issue that language is being added to the AHP plan doc. So a bank that offers telemedicine can essentially piggyback on the compliance of Advantage Health Plans through their membership.
Yeah.
So you don't have to go out and hire an attorney to write your new plan document for your telemedicine program.
Sure. And then the last plan change that we'll talk about for the medical plan is actually an eligibility change. So many of you all probably remember several years ago when the Affordable Care Act, it kind of became the conversation, part of our everyday lives, that eligibility was something that had to be addressed. And the Affordable Care Act required that employers offered coverage to employees in any class that met a certain number of hours for eligibility. At the time, Advantage Health Plans and with the assistance of Maria kind of polled the population and the participants of Advantage Health Plans to determine what what the actual hours were that were being worked by employees of the participating employers, so that we could identify what compliance was required and what changes would be required by Advantage Health plans, if any. At the time, the decision was made to maintain the 32-hour benchmark, such that any employees that worked at least 32 hours or more per week would be eligible for the plan, and any employees that were below that threshold would not be eligible for the plan. Recent guidance and just kind of the evolution over the last several years of just, regulation and additional information that kind of has come out would suggest that it's probably time for us to go ahead and make a change to that hourly threshold or that minimum hour requirement. So with the assistance of legal counsel, the trustees did accept a recommendation to go ahead and change the hours for eligibility from 32 hours per week and move that down to 30 hours per week. So that change will actually take effect January 1st, 2020. So if you're an employer that has employees in a category that the employee is working more than 30 but less than 32, and you need some assistance and maybe working on enrollments and communicating benefits information to that class of employees that perhaps has not prior been included in any of those conversations, we can certainly assist you with that. You can talk to your account manager over at the Kempton Company so that we can help you through that process. What I will also tell you though is, as a result of conversations that we've had with many of you, probably, and this is probably still the case, probably many of you, if you had employees that were not meeting the 32-hour threshold, the folks that were not meeting that threshold are probably also working below the 30 threshold. So my point in telling you that is that this is not intended in any way to be an additional compliance burden that you all would have to face. In fact, on the opposite end of that, it is a compliance requirement, but at the same time not intended to impact you, rather intended to assist you. Let's just talk quickly about vision. We kind of get a lot of questions about the vision plan, just from the perspective of have the allowables or the frame allowances that are included on the plan, have those evolved over the years? They haven't, so we're going to evolve them now. So Jay mentioned earlier when he talked about the renewal that we are not having a rate increase. We are getting a flat rate adjustment for the vision plan, but what we are going to do is to enhance the benefits of that vision plan. So some of y'all may be familiar that there was for an annual well vision exam, you paid like a $20 copay, and you could have your eyes checked essentially every year. We've actually, with the new plan that we'll be implementing, we're going to reduce that annual well vision copay down to $10. So that will be an enhancement. Some of the other enhancements that are available on that plan is going to be an increased allowance for things like frames and contacts. And it, when we look at things like disruption and the number of providers that are available under this plan in comparison to the number of providers that would have been available under the prior plan that everybody's enrolled in today, there's no disruption. So essentially the summary here is that you have access to all the same providers that you would have had access to when you were participating in the VSP plan, the VSP vision plan under the Signature Network. All of those same providers would be available on the VSP plan that will roll out January 1st, 2020, but you'll have more to use towards your frames and your contacts and less to pay for your well vision exam.
Win-win.
It's a good set of facts. Quickly, I'll just kind of talk about where we go from here in 2020, and kind of what the successful profile of an employer that has adopted Advantage Health plans might look like to be able to achieve some better results or some improved results next year. First of all, we would just really like to encourage every employer to place a focus on an employee meeting through the end of this year and even going into 2020. There's a number of different ways that you can offer an employee meeting. We have over the last couple of years done some remote presentations so that we can broadcast to all of the branch locations or any of the places where you have employees. We've recorded both live presentations as well as some pre-recorded presentations. So we would just like to encourage everybody to place an emphasis on scheduling that employee meeting and getting all of your employees in the same room where we can have a conversation about the health plan. We recognize that your plates are full and that you also have a lot of compliance requirements that you've got to deal with in your places of employment, but at the same time we also recognize the impact that just continuing to have these open conversations and providing education to your employees can have. So we want you to be able to have that opportunity if you desire. Also, I think it's important to talk about, employers adopting a culture of consumerism or cost containment in your organization. It's a timely conversation because we're talking about the renewal. So if you're, and I promise I'll talk to each of you if you have questions about what your particular renewal will look like. We will be getting those out in the next couple of weeks. But oftentimes this question kind of comes up at renewal time whenever costs look like they are going to be adjusted, particularly adjusted to the positive side or going up. But I think if we can, place an emphasis on that culture of consumerism within your organization and not just make the conversation about your health plan something that we have once a year, but rather something that we do and that we reinforce on an ongoing and a regular basis, I think that there is where you will see the measurable gains in the adoption of some of the things that we've talked about. Whether it be, I talk to banks sometime that have a monthly, all staff meeting. And so the health plan is always an agenda on the monthly staff meeting. I talk to employers sometimes that they've even revamped their PTO policy, their paid time off policy to support employees that are needing to have procedures done, and they choose to utilize some of the providers that are available through these enhancements that we talk about. There's lots of different, what that means to you as an employer might look different than what it means to another employer, but adopting that strategy and making sure that you place an emphasis on the education and the cost containment within your organization, I think is the important thing.
We'd love to help you get creative on something that makes sense in your bank.
We have lots of educational materials, so you all know that this year we enhanced the employer portal, and so employers as well as employees have access to a robust, resource to be able to look at flyers. Those are great pieces to just shoot out in an email to your employees as well, but they also, if they register and log in through the employee portal, they also have access to some of that information at their fingertips, so take advantage of that. And then I think also just, we talk about these things very regularly. So the acronyms and the benefits kind of roll off of our tongues. We recognize that perhaps is not the case for you all, but we would like to encourage you to just promote and encourage the utilization of, the KDAP program, the DPC providers, the KPP free. And I think the way that you do that, which is probably the simplest thing, is just to have conversations with your employees, reminding them that there is an advocate available in their health plan by contacting someone at the Kempton Group and speaking to an advocate in our customer service call center, and let us walk you through it. Have those conversations, but at the same time know that we have the people available that are skilled and do have the ability that we do have these conversations every day. So just support them and reminding them to contact us if they need help. Couple of just additional helpful tools and resources. We provided a pre-recorded employee meeting in 2018 going into the 2019 year. We'll do the same this year going into 2020. Those are great meetings to have available and on demand also when you hire new hires, so that they also continue to receive the same message throughout the year. From a compliance standpoint, employers do have a requirement to make sure that annual notices are provided to participants that are enrolled in their health plan. That's a compliance burden that Advantage Health Plans has actually checked off for you. We have all of those model and annual notices available. They're actually on the employer portal. If you need help with finding any of those, we can help you find those, but both your employees as well as the employer at their level of access has access to pulling those model and annual notices down from our portal to help you check that compliance burden. One of the things that we get asked on a pretty regular basis is when a bank particularly has an examiner in their bank and they're doing due diligence on the vendors that the bank does business with. So we get asked a lot of times for a due diligence packet, and there's some information that we include in that due diligence packet and provide upon request to the banks that ask for it. If you're getting those requests, please reach out to us. We can assist you with putting that together to meet those requirements to satisfy the examiners in your bank. We are actually putting together a packet that we'll have available for public distribution that will be available, at your request. That should be available probably by the end of the year to meet some of those, to check off some of those boxes. They include things like, the audited financials of Advantage Health Plans and the trust, some of the required insurance and liability policies that are available, some of the security and those types of policies and for privacy and that type of thing. So be on the lookout for that. In the meantime, if you need some assistance with that, we can help you put that together. And then just a quick reminder, as we come to the close of 2019, be on the lookout for our communications out to you all regarding the Affordable Care Act or the ACA reporting. If you're a participant of Advantage Health Plans, if you're an employer that is, offering Advantage Health Plans, which is a self-funded health plan, you've got a reporting requirement. And sometimes there's a little bit of a misnomer that the only employers that are required to report are employers that have more than 50 employees. I think that it's important to know that all employers that are participating in a self-funded health plan have some level of a reporting requirement, one that we can help you with. So typically around September, October timeframe, we start sending out communications to let the employers know that this is coming. There's some deadlines coming up. We can help you with this reporting. It's certainly not a requirement. If you all have confidence in your organizations to be able to do that on your own, we certainly support that and can provide you the information to do that. If you need assistance, we also can help you with that. So be on the lookout for those communications so that we can make sure that if you need the assistance, we can get you in by the deadline and provide that reporting for you. Great. I think that's all I have.
We're 10 minutes past, and I know. It was like cramming, 40 pounds of flour in a 20-pound bag. But we have Troy Stillwagon, our CIO. If you guys can hang tough for another 10 minutes or so, if not, we certainly understand. But he was we wanted him to go through some of the new portals and the new capabilities real quick before we end this presentation. So with that, Troy.
Okay, I can't talk as fast as Melissa, but it does give you a glimpse of my conversations that I have with her because she can talk very quickly. But I can cut out a lot of what I was going to say to make this as quick as possible. I'm very excited to be with the Kempton Group and supporting the Advantage Health Plan Trust. Excited with everything that was presented today. I mean, it just shows really what thinking out of the box as far as healthcare and providing that to your employees and trying to cut down cost. And I come from a large provider network, spent pretty much 29 years at a large provider network. But what it did bring me was technology, and it taught me, and I grew up on technology and how to utilize it and how to implement it appropriately and how to have good vendor relations. So all I want to do today is bring you just a quick touch of something that we're bringing to you that's new. Jay, if you can just, let's kind of skip this slide, go to the next slide. Yeah, let's stick there.
Right there?
Right there for just a second. So basically, the first slide, which you have in your packet, is just reminding you of the functionality that we have through either our member portal or our employer group portal. which I hope all of you are utilizing as much as possible. Like Melissa said, we have a lot of good material that we put out there, and we have a lot of things to view, especially from a member standpoint or from the employer group HR standpoint if you're doing HR administration. What I'm very excited to talk to you about just real quickly is the fact that our current functionality that we have within the employer group portal just allows you really to view information, but doesn't allow you to really do anything as part of that. And so what we're bringing to you is we're rolling out new functionality that allows you to do eligibility management and enrollment for the new upcoming open enrollment system. So we're looking at, we've already done 3 webinars on this, and we've only we had about 20 groups sign up. We have about 115 groups we're trying to participate in the webinars. We have 3 more that are coming up, and I'll show you those dates here in a moment. But we really, truly would love to have you participate in this. Now, I will tell you, if you can't get to a webinar, if you're somebody if you're HR administrator or you're the person who does that, if you just can't make it, we have taped what we think is the best of the 3. We've taped all of them, but we've selected what we think is the best of the 3, where we had a lot of questions associated with the webinar, and we basically have put that out on the website. You can go out there and you can view that. But being part of the webinar allows us to know that you took part in it, and then it allows us to get you access to this system to be able to use these capabilities. As you can see, the new functionality basically allows you to do things such like enroll, or if a new employee in the system, and select the plan that new employee is gonna have, either during open enrollment or just during the year for a qualified event where they're a new employee that's joining. It allows you to modify coverage during open enrollment, enroll and decline or modify dependent coverage, add or modify beneficiaries if applicable, if you have life benefits or long-term disability or something that requires basically you to be able to have beneficiaries. And then it also allows you to modify just personal contact information. I can tell you that one of the best things this does is it allows you, once you've submitted all this information, to also follow exactly where it's at in the process. And one of the reasons, the why we're offering this is right now, with the exception of about 15 or 20 groups that have payroll companies that send us standardized files, right now we get pretty much anything from you. If you've heard the webinar, you've heard us talk about that we either get paper sent to us in the mail, we get emails, we get text. I think I even said we get carrier pigeon, or we would accept carrier pigeon.
Don't forget faxes.
Fax. We get faxes. We get all kinds. Now, what that brings to us is that just really slows down the process. It makes it where we don't have any kind of standardized process. And so part of what I'm trying to bring and what Jay and our group's trying to bring to you is just better processes, more standardized technology processes, so that we don't miss something in the process. Because if we get an email, and we've had 100 emails on that day, and one of our administrators gets an email, we don't want to miss that email. It's just kind of an inefficient system that we have in place with regards to enrollment changes or new enrollments, and we don't want to miss one of those. We don't want anything to happen to one of those. This standardizes the whole process. You basically enter everything into the system. If you've been part of the webinar already, hopefully you've seen that we think it's a very easy system to use. And basically, once you submit that person for enrollment, then that goes to our admin team. The admin team just reviews it to make sure it's good, and then that goes into an automated, standardized process. That then it basically, every file that comes out of that system is a standard file that we can process automatically. So it just has a lot less touch points within our system, which we think saves money. And we are just highly encouraging every bank to
Reduces errors as well.
do what?
Reduces errors as well. And
Very much so.
And at some point in the future, when we get most of the banks implemented on this, our goal is, if a bank is interested, then going ahead and extending it to be released out to the individual employees. So you have a new employee that comes in, so you just need to go out to this website and then self-enroll. It's a big step, and we're not ready for it right now, but that is the end game.
Yes, so we're rolling it out to those who do kind of the HR admin for this season up through the end of the year, and then at the beginning of next year, we'll start rolling it out to the banks that want to have your employees, as Jay just said, want to have an employee getting out there and just selecting their own plan. We're going to start that at the beginning of next year.
And we are seeing more and more banks that, especially some of the larger institutions that have purchased a benefit enrollment module through a payroll company. Those are things that we were able to do those implementations very, very quickly, as far as being able to accept, again, as Troy said, the industry standard file formats that are output from those payroll companies. And so those benefit modules where you go out and you do the enrollment into the benefits the same way you do when you're setting them up on payroll, and then it comes to us and we get it loaded into our system. So there's really two avenues here. Don't think that because we're rolling out this portal that, if your payroll company's got some dynamite benefit module that you just can't wait to sign up on, we can support that as well.
Yes, thank you. So really the last slide, Jay, if you'll just go to that. Yeah, right here. This just says you're utilizing the same system you use today. It's at advantagehealthplans.com, and you go to your employer group portal by clicking on employer group. And then you will basically see a eligibility management quick link that you click on, and then that automatically, based on your login you already have to the system, it will give you the ability to do these functions that we've talked about. And then 3 webinars. We're going to possibly add a couple more webinars after this, depending on how many we get to sign up for this. And I think right now we probably have another 15 or so that are signed up, but we just would love for you to sign up, participate in this. And if you have any questions about any of this, I'll be hanging around also, and be happy to answer your questions. All right.
Okay, thank you, Troy. I'm sorry that we went 20 minutes over, folks, but we are at the end of the presentation. We'd like to open it up to questions, or we can always just do questions as you roll out. But does anybody have any questions for the group? All right, well, we're between you and dinner probably, so, but obviously we're always available any time, way, or fashion. If anybody has any questions or comments, we would love to assist and field those questions any way we can. So thank you all so much for coming out. Thanks everybody online for their time and attention as well.